Yes, ma'am, we are on live. Just let me
Yes.
share to our group.
Yes.
Okay, ma'am.
Yes, Rafi, can I start?
Okay, ma'am. Now we can start. আসসালামু আলাইকুম, শুভেচ্ছা সকলকে। প্রতিবারের মতো আমাদের আজকের লাইভ শুরু হতে যাচ্ছে। আমাদের সাথে আজকে আছেন ডক্টর ক্রিস্টিন জর্জ ম্যাম, MBBS গোল্ড মেডালিস্ট, MD ইন্টারনাল মেডিসিন অ্যান্ড MD ইন নেফ্রোলজি। উনি বর্তমানে অ্যাস্টার হোয়াইটফিল্ড হসপিটালে ব্যাঙ্গালোরে কনসালট্যান্ট নেফ্রোলজিস্ট এবং রিনাল ফিজিশিয়ান হিসেবে কর্মরত আছেন। আজকে আমাদের টপিক ভেরিয়াস ট্রিটমেন্ট অপশন ফর কিডনি ডিজিজ ইন ডিফারেন্ট স্টেজেস। শুরুতেই আমি আমাদের গ্রুপের পক্ষ থেকে ম্যামকে শুভেচ্ছা জানাচ্ছি। Thank you, ma'am, for joining with us. I'm welcoming you on behalf of our great group, on behalf of our community. About 2,000 patients are here, and most importantly, we all of our kidney patients. And I will thank you again, ma'am, for being with us. And now we can start.
Thank you, Rafi. It's my pleasure to be here. And namaskar, assalamu alaikum sabiko. We will today try to discuss a very important topic that is about treatment of kidney disease in various stages. So I have made few slides to introduce the topic, and so that you can understand how important it is to diagnose the disease early and to take the right treatment at the right time. Rafi, if you can share my slides.
Yes, ma'am.
Yes. So we all know that kidneys are large cleansing factories. They are cleaning our blood every second as we are talking. And they are simple bean-shaped organs about the size of your fist, which are located behind on either side of your spine. And the main job is to keep your body's chemicals in balance. And they do this by filtering waste and toxins out of your blood, and they produce urine as a result of this, which carry the waste products out of your system. And both the kidneys together filter about 1,800 liters of blood every day. That is, your entire blood goes through the kidney about 300 times every day. And then the final product is the urine, which is made, which has all the waste products, and also by this the kidney maintain a very fine balance. And this is done by small microscopic filters within each kidney. So it is not that the kidney is like a huge filter, but it is rather there are microscopic small filters, about 1 million of these filters in each kidney. These are called glomeruli. Glomeruli are the functional units of the kidney. Yeah. So now coming to kidney disease. What are the causes of kidney disease? Worldwide, the commonest cause is diabetes. We all know that the diabetes prevalence is increasing by leaps and bounds, especially in the South Asian population in India, Bangladesh, and these countries now are soon catching up, and India is becoming the diabetic capital of the world itself. So this is the most common cause of kidney disease. Next, there is a group of disease known as glomerular diseases. I mentioned that the functional units are glomeruli within the kidney, and there are certain diseases which cause specific inflammation in the glomeruli. We call glomerulonephritis. And this is again very common, and a large proportion of patients suffer from this, but unfortunately get diagnosed at very late stages. I'll come to that in subsequent slides. High blood pressure is a cause of kidney disease. Again, if BP remains untreated for many years, slowly over many years will cause kidney injury. Then there is a group of disease known as interstitial disease. So within the kidney, apart from these small microscopic filters that is glomeruli, there is the surrounding tissue, which is the interstitium. There can be diseases which affect the interstitium, which can result in chronic kidney disease and kidney failure. Then there are certain drugs which are known to affect your kidney, especially painkiller intake, sometimes these alternative medicine, herbal medicine intake, the so-called safe medicines can have adverse effects on the kidney over long term. Then there can be kidney stone diseases. Stone formation in the kidney, again, very common among our tropical climate. Kidney stone formation, if not addressed and prolonged and recurrent stone formation, can cause kidney damage. Then there are certain diseases like cystic diseases. Cysts are nothing but fluid-filled balloon-like structures which form in your kidney. And this can happen as a part of aging, but if it happens at a younger age and in large numbers, it can cause kidney damage and kidney failure. Then there are certain inherited diseases. That is, by birth, you are born with certain abnormal genes which can result in kidney failure as you age. Then there are infections. You get urinary infection, which goes on to develop pyelonephritis or infection in the kidney, causing kidney failure. So this is not a complete list, but this mostly covers the common conditions which we encounter. Now, before we go on to the treatment per se, you should know that it is important to understand if you are at risk of kidney disease or not. This is for general public in general, because most of the patients do not know they are suffering from kidney disease. So if you have a family history of kidney disease, if you are a smoker, if you are obese, if you have history of heart disease, you have diabetes or high blood pressure, you should ask the doctor who's seeing you to check you for your kidney function. Okay, so kidneys do not give rise to any pain or any symptom till very late stage. It is important to get yourself tested. Please ask your doctor if my kidneys are working fine. How to prevent? So prevention is always better than cure. Once you know you are at higher risk, please, one is to get yourself tested, and it is just not a one-point test. If everything is normal, please repeat the test every year. Maintain a healthy weight. Do regular exercise, avoid smoking, and salt restriction. Again, it is proven that it in the long run is kidney protective. Good sugar and blood pressure control, and avoid over-the-counter medicines. These may appear like a very general 5-6 points for prevention, but these are very, very effective methods of preventing kidney disease if followed. Next, how do you know you're suffering from kidney disease? So there are certain symptoms which can suggest, for example, dry and itchy skin, tiredness, you feel that your urine has bubbles or it is foamy, you find you have swollen legs or ankles, puffy eyes, especially when you get up, lack of appetite, lack of sleep, muscle cramps, your need to go to washroom frequently. These are some of the symptoms which can indicate you are suffering from kidney disease. But again, as I mentioned, kidney disease is mostly silent and the symptoms may be late to appear. So earlier stages can be completely asymptomatic, and that is why kidney disease is called a silent killer. You know, heart attack or heart disease, when you'll get some chest discomfort. While walking, you get chest pain, you rush to a cardiologist. You know, if you're having weakness somewhere, numbness, you will go to a neurologist. But unfortunately, kidneys, you know, they are such organs that they are silently working, and even when they are in trouble or when they are not able to work properly, they do not give rise to any pain or any symptoms. That is also the reason why it is a silent killer. And it is alarming to know that 1 in 10 people are affected by kidney disease worldwide. So in any, you know, you go on the road, you take randomly 10 people, there is a probability that one of them may be having kidney disease. Just imagine the huge, enormous number of patients who are suffering from kidney disease, and majority are not aware. That is a whole problem. That is also why this topic needs to be discussed more and more, because even in a city like where I'm practicing in Bangalore, it's one of the highly populated, it's the IT capital. We see a lot of educated professionals here, but still we are seeing patients, you know, who come in very late stages of kidney disease. We have even seen diabetics never getting tested for kidney function, creatinine or urine test, till very late stages. When they come in, advanced kidney failure. So that is the amount of ignorance or lack of awareness among the public. So coming to the stages of chronic kidney disease. So when we say chronic kidney disease, what I mean is there is some amount of injury that has happened over a long period of time, which has caused some kidney injury. And we have a staging system, you can see here, based on the GFR. Okay, GFR is nothing but a filtration number, I would say. The full form is glomerular filtration rate. In simple terms, it is the, you can call it a kidney number or a filtration number. This is again something which is derived from your serum creatinine. Serum creatinine is a simple blood test, and a GFR is calculated based on your creatinine, depending on your age and various criteria. Okay, so your GFR is something which you should know. What is your kidney number? As you can see here, in early stages of CKD, the GFR or the G1 stage, wherein the GFR is actually more than 90. More than 90 is considered normal. But why is it then chronic kidney disease? If this is associated with some proteinuria, let's say some abnormal urinary sediments, then it is still indicative of an early stage of kidney disease. Okay, so you should know your GFR. And as age advances, usually the GFR tends to fall, but which is normal. There is a normal decline. Coming back to stages, as I mentioned initially, G1 is more than 90, then there is G2 wherein it is 60 to 90, then G3, 3A and 3B, it is 45 to 59, and then 30 to 45, like that, and G4 and G5. Okay, when it is less than 15 is G5. That means the filtration rate is critically low, and this is a stage wherein we have to plan renal replacement therapy. Again, depending on the albuminuria, proteinuria, there is a classification as A1, A2, A3. Okay, so these are, again, I'm stressing upon that these are numbers which you should know. Especially, let's say you are a diabetic. Your sugars are well controlled, which is a good thing. But do you know what is your GFR? Do you know what is your albuminuria? Okay, this is very important. If you know whether, if it is recent, you should know it annually, how your GFR is changing, how your albuminuria is changing. And if any of the two is abnormal, then you will require a frequent monitoring in addition to therapies, which we'll be discussing subsequently. So now we discuss what are the stages. Now, why does a patient progress from stage 1 to stage 5? So there are various mechanisms. Okay, so let us say there are certain factors which are non-modifiable. Non-modifiable factors are there leading to renal disease progression. For example, somebody may be genetically predisposed to develop certain type of kidney diseases. You are born with some abnormal genes. Or there are some diseases which are more prevalent in men compared to women. Somebody already having a kidney disease will progress faster. What is the age? If somebody starts having a kidney disease very young, the probability is much higher that they will progress in their lifetime. Versus somebody who starts to have kidney disease at 60, 65, you can still manage it. There is something known as fetal programming. Somebody who has been a low birth weight baby to bond with, you are born with less number of nephrons. So going forward, you are more susceptible to get kidney disease and kidney failure. So these are things which are non-modifiable. You cannot change the genes you are born with. You cannot change, your birth weight or your genetic predisposition. So these are non-modifiable. Then there are some general metabolic risk factors. For example, obesity. If you are on the heavier side, it is definitely a risk factor for not just developing kidney disease, but for faster progression of existing kidney disease. So this is a metabolic factor. Again, there are factors like diabetes, metabolic syndrome, atherosclerosis, which will result in faster progression. There are certain environmental risk factors like nutrition, smoking, which are factors contributing to progression of kidney disease. Now coming to CKD related, of course, there are metabolic acidosis. Generally, when creatinine goes up, acid levels build up in the body and uric acid becomes high or lipid becomes high. That itself can result in faster progression. So these are factors we try to modify as nephrologists so that the disease doesn't progress faster. And coming to the mechanism, what is happening within the kidney is leading to progression. So protein leak itself, okay, protein, once it is continuously leaking in your urine, will cause kidney damage. This is very important to understand. Protein leak, why it happens is because of an initial insult. Okay, there has been an insult, there is an injury, and protein is leaking. Now, protein leak itself will further cause injury. So, it is important to control the protein urea or protein leak. Then there is a system within the kidney known as RAS system, okay, renin-angiotensin system, which is like a feedback system. But once the kidneys are damaged, this feedback system is overactive. So the kidneys try to preserve a lot of salt water that causes hypertension, and RAS activation will itself cause in more fibrosis and kidney damage. So that becomes a vicious cycle, and it becomes a counterproductive mechanism within the kidney. High BP, systemic BP, and within the glomeruli, high pressure will lead to progression of kidney disease. And of course, there are other factors like anemia, inflammation, oxidative stress, which will contribute to kidney disease progression. Okay, so this is an important slide for you to understand. There are so many factors which we can modify. Okay, many people, and it's a very common perception in the mind of people that, oh, I've been told to have kidney disease. Kidney disease don't have any treatment. My doctor has told nothing can be done. Okay, kidney disease is not treatable, which is a wrong idea. That is what I'm trying to tell. There are so many factors which are modifiable. Okay, and we'll come to this in little more detail. Yeah, so let us first see the most common cause of kidney disease. As I told, it is diabetic kidney disease. Again, as I mentioned, early detection of diabetic kidney disease is most important thing. So if you are a diabetic, please get yourself tested at least yearly once. Okay, and creatinine alone is not enough. This is the very important point. Getting your creatinine alone is not enough, because in the early stages of diabetic kidney disease, your serum creatinine value in fact drops below normal. See, normally for, let us say, an adult male, we say that 0.9 to 1 or sometimes 1.2. 1.2 is normal for an adult healthy male. But in early stages of diabetic kidney disease, a creatinine may be like 0.8, 0.7 for an adult male, or even 0.6. They may be very happy, my creatinine is bilkul normal, 0.5, 0.6. But actually, this is a stage wherein kidneys are hyperfiltrating. They are functioning more than what is healthy. You know, they are functioning very, very high, and that is hyperfiltration, which is not good. They hyperfiltrate, and there is protein leak in the urine. And the patient will be completely asymptomatic at this stage. Let me tell you, you will not find any abnormality in your urine. You will not find any swelling. Unless you get yourself tested, you're not going to diagnose at this stage. And this is again important to understand, because patients will be healthy. They feel, I don't have any disease. How can I have a kidney disease? My sugars are controlled. I have no problem. Why should I get tested? So this is unfortunately also the reason why, as I mentioned, these things should be discussed more and more. This is a stage wherein it is completely haltable. You can stop it at this stage, so that diabetic kidney disease does not progress. In fact, proteinuria can be completely normalized. So please get yourself tested, not just creatinine. You should get a urine evaluation, okay? Urine routine and a urine ACR. ACR is nothing but an albumin creatinine ratio. Any good lab, wherever you are, you can get it done. You can ask whoever is seeing your diabetes. Many endocrinologists, diabetes nowadays are doing it themselves, and of course they manage this well. But again, diabetes is very common, and a lot of doctors are managing it. So it's important for you as a patient to understand this, and you have to take up the responsibility of your health. So get yourself tested. Know your numbers. 2 numbers you should know. One is, what is your GFR, or glomerular filtration rate? Next, you should know what is your ACR. That is albumin creatinine ratio. What is your albumin leak in urine? Okay, you should be aware of this. Next, what are the treatment options? So there are at least now 3 groups of drugs which are like the 3 pillars of treatment for diabetic nephropathy. So ACE inhibitors and ARBs, these have been there for many, many years, but they are still one of the best group of drugs to reduce. Yeah, you would have seen these drugs, telmisartan, losartan, enalapril, ramipril. These are commonly prescribed. But one important thing is the dose at which they should be given to reduce proteinuria is not the same as your antihypertensive doses in many situations. These are also commonly used as antihypertensives or blood pressure lowering medicines. They do lower BP, and more so they lower protein leak, but they should be given in the right dose. Many times we have to increase the dose to much more than what is given for blood pressure control. That is important. And again, many times these drugs can cause some high potassium, some transient or increase in creatinine can happen. And if the treating physician withdraws the drug and forgets to restart, the patient loses on the benefit of the drug. Again, a very common situation. If you're on these drugs, you get fever, vomiting, or loose stools, it can cause creatinine to go up and potassium to go up. That is what I mean by sick day rule. When you're sick, these are medicines which you should not take. Once you're well, you should restart the medicines. Okay? And it is important to restart. Of course, you should
one question.
Yes.
Ma'am, does AAC inhibitor increase creatinine level?
Yes, so that is a very good question. See, yes, ACE inhibitors do increase creatinine level. But what you have to understand is the GFR, the filtration rate, as I mentioned, the initial stages, the filtration rate, in fact, is higher. Okay, let's say normally if the GFR is, your average GFR is 100. But when the kidneys are hyperfiltrating, your GFR would go up, and which is not good. Which is not good in the long run because it will damage the kidneys soon. So we want the filtration rate to come down, and these drugs will reduce the filtration rate. Okay. Now, for example, we are starting with a lower GFR. Let us say we are starting with a GFR of around 70. Okay, which is not normal. Maybe the creatinine is mildly elevated, 1.2, 1.3, like that. GFR is around 60 or 70. Let's say 70. Now, there is protein leak. And we start a medicine like ACE and ARBs, telmisartan, let us say. If it is really working well, it will reduce the filtration rate. That is what we want. And the GFR will drop from that 70 to, let us say, 65. Okay, and creatinine will increase. Creatinine increasing and GFR dropping, that is same thing. Creatinine increase means GFR has dropped. Okay, which is okay, which actually means the drug is acting well, and this is going to give long-term nephroprotection. Okay, but again, having said that, it is important to monitor. There are certain specific kidney conditions wherein these group of drugs can cause sudden drop in GFR. Creatinine can go up beyond what is expected, I mean to say. Okay, in that situations, we may have to hold it, we may have to stop it. So it is important to start, but also it's important to monitor closely. Okay, just because the creatinine has increased by 0.1, 0.2, we should not rush into stopping. At the same time, we should, for example, there are situations if the patient is running fever, vomiting, if you continue to take the drug, creatinine can really go up. There are situations wherein it should be stopped and then restarted. They are very good drugs, but like any other drug, they have their own set of cautions. Okay. Now, coming to the next group, that is SGLT2 inhibitor. You would have heard drugs like dapagliflozin, empagliflozin. Okay, these are commonly used nowadays for diabetic patients. This was developed like a anti-diabetic drug. But the kidney benefits are much, much higher than actually sugar lowering benefits. So this graph may look complicated, but the simple thing what I want to show you here, if you see the yellow, okay, the yellow graph is somebody who is not on SGLT2 inhibitor. This is from a very large randomized controlled trial, which was done for this particular group of drug. This shows the drop in GFR or the slope of GFR. You start with the GFR around 60. Within 10 years, okay, for this patient, the GFR has dropped to 10 and the patient lands up in dialysis. Okay. Versus somebody whom we have started on this group of drug from 60. Initially, there is a drop of GFR. You can see here. From 60, it dropped to 50. That means the creatinine increased after starting the drug. Similar to telmisartan, losartan, even this group of drug will cause some creatinine increase initially. But see, after that, what happened? The curve has really changed. Okay. Whereas this patient is landing up in dialysis at 10 years, we are looking at 25 years. That means 15 additional years of dialysis free life. You understand? I hope this is clear. If not clear,
Yes,
I can stress upon. Yeah. So this is very important to understand. Many people don't realize this when we explain in the clinics also. Okay, the benefit is on a long term. See, this is a decline of GFR which is happening over 10 years, whereas we have changed the curve to this using these group of medicine. And this is developed over the last, let's say, 5, 6, 7 years. These are medicines which have newly come in the market. And so these are the SGLT2 inhibitors. They have multiple mechanisms how it helps the kidney. And then there are RAS inhibitors, I already told you. Of course, statins also help. And then there is a third group of medicine, again newly introduced. These are known as non-steroidal mineralocorticoid antagonist. And they also provide protection. It is a newer addition to the armamentarium, and it also slows down the decline in kidney function. Okay, decline in kidney function is inevitable. As a part of normal aging also, there is a slope. Okay, like not so drastic as I showed in the previous picture, but there is a decline. What we are trying to do with all these medicines is to slow down the decline. Okay, and it is a huge benefit. As you saw, 10-15 years difference, treatment versus no treatment. And this is again a very effective group of medicine which has been shown by large trials, but important to choose the patients wisely. Any medicine which will act or which will really have a effect can also have a side effect profile. We should be aware, should monitor and manage accordingly. That is important. Now, that is about diabetic kidney disease. Now, another group of important group of diseases is glomerular diseases. So, glomerular diseases or glomerulonephritis, some of you may have heard. It is an immune mediated. That means your body's own immunity is acting against your kidney cells and is causing damage. Okay. What is important in glomerular disease is timely treatment with immunomodulatory drugs can achieve disease remission. That means if a glomerular disease is diagnosed in time, okay, wherein the antibodies are actually causing the kidney injury, you have medicines to control that immunity or modulate that immune response so that the disease comes into remission. Okay. And untreated, majority of disease will progress to end-stage renal disease. And what is important is most of the age group in this disease is young, 20s, 30s. These are the group of patients who are suffering from glomerular disease or who are prone to develop glomerular disease. And these are diseases which you cannot alter by, diet or things. There's no proven data that just by eating healthy, you are protected of glomerular diseases. Okay. These are
reversible.
Sorry?
Is it reversible?
Yes. So that is what I'm trying to tell. Reversible is a very heavy term, I would say. Most of our chronic diseases are, it can be brought under remission. Some of these diseases will as well, you can tell, reversible, definitely. If there is a proteinuria, there is elevated creatinine, many of these patients come to normal protein, normal creatinine. That way, yes, injury is reversible. But the disease in a lot of places doesn't completely go away. We have to manage with some medicines. Okay. But having said that, the diseases completely can be brought to a quiescent stage, like sometimes patients completely come off the medicines. We give a short course of immunomodulatory medicine, then the disease is not there. It's like completely reversed. A lot of these glomerular diseases are like that. So it's very important to pick them at the right time. And if you don't pick them up, they progress to ESRD. And the IgA nephropathy is now it's the most common cause of glomerular disease. In fact, a lot of our patients who come for transplant in their 30s or even in 20s, they have suffered from IgA nephropathy and landed up in a dialysis requiring stage because their IgA was never diagnosed. So that is
one question.
Yeah.
Now, as I'm seeing, many of us are went through a transplant and after sometimes IgA nephropathy regenerating. Is it common to regenerate after transplant IgA nephropathy?
Yes, so IgA is a disease which is known to recur in the graft kidney because, as I told, it is an immune-mediated disease. So your body's immunity itself is producing these abnormal IgA. So your body's immunity is still producing, but usually even if it recurs in the graft, it is not so aggressive like how it was in their native kidneys because we are already giving you immunosuppressants after transplant. So the disease is largely kept under check, and transplant kidneys usually it doesn't affect as much as it affects your native kidneys. Okay, we manage with immunosuppression because we are diagnosing it early in a transplant situation. No, in native kidneys you would have got it diagnosed much later, and in transplant because we are following closely, we pick up the disease early and we adjust certain medicines in your medications, and then the disease is kept under check. Okay, and there are other glomerular diseases like FSGS, that is focal segmental glomerular sclerosis, MGN, ANCA vasculitis, SLE, lupus nephritis. These are some of the common glomerular diseases which can cause kidney injury and kidney failure. So again, here early diagnosis is the key factor. If you have any of these symptoms, frothy urine, cola colored or blood in urine, puffiness around the eyes, please get yourself tested at the earliest. And if there is any abnormality, especially if you are young, you're not a diabetic long standing and you're found to have some protein leak, please get yourself tested. And if somebody advises for a kidney biopsy, please get it done. Again, another thing is I'm talking about especially native kidney diseases wherein we don't know what is the cause for proteinuria, and people are scared of kidney biopsy. Kidney biopsy nowadays is a very safe procedure which is ultrasound guided, and that is the only thing which can give you a diagnosis. And as I told, glomerular diseases with right treatment is reversible, and we can keep the disease under check. Kidney biopsy is the only way in most of the situations to clinch a diagnosis, and it is a ultrasound guided procedure we ourselves do bedside under real-time ultrasound guidance. So this is a case to just stress upon the fact that any proteinuria detected on urine examination is abnormal. This is a patient I recently had actually. The 40-year-old gentleman recently detected to have high blood pressure, noticed to have some frothy urine, and he reported to his physician. Urine dipstick was asked for, as anybody would ask, showed some 1+ protein. Creatinine was absolutely normal. So the physician naturally reassured the patient saying it could be associated with your high blood pressure, let us monitor. After 8 to 9 months of this, patient was observing this frothy urine and he was concerned and asked for a nephrologist's opinion and came to us. And on quantification, there was 3 grams of protein leak. So this 1+ trace protein does not always mean it is very low. So 1+ protein on urine dipstick actually showed 3 grams of protein leak. For us to understand, the normal protein leak is just 150 milligram. And he had 3 grams of protein leak. That is 3000 milligrams of protein leak. So there's a huge amount of protein leak. So we advised a kidney biopsy. We did a kidney biopsy rather. And we found a glomerular disease, that is membranous nephropathy. It is an immune-mediated disease. And it has very specific kind of treatment. Now we have targeted treatment, in fact, in the form of tablets, or he can just take 2 injections and then the disease usually goes into complete remission, not even requiring continued treatment. If it was left undiagnosed, it would have in most situations progressed to an end-stage renal disease in a couple of years. So it's very important to understand that all proteinuria needs evaluation. Okay, all proteinuria, if any time detected, needs further evaluation. Not all proteinuria will need biopsy, but definitely further evaluation is required. So what are the treatment options for glomerular?
One question.
Yes.
What is the parameter of going to biopsy?
So
With
in
photometer.
a transplant patient versus a non-transplant patient, the criteria are different, I would say, for biopsy. Okay. In a transplant setting, our threshold for biopsy is much lower because let's say we see some elevated creatinine, unexplained protein leak. We do biopsy in a transplant setting because there can be rejection, there can be recurrence, there are a lot of possibilities. In a native kidney, somebody who's diabetic long standing is having some proteinuria slowly increasing. He also has some diabetic retinopathy, other changes of diabetes. We do not generally biopsy. We presume it to be related to diabetes as a diabetic nephropathy. But there are cases in diabetes also where we biopsy. For example, suddenly somebody comes with lot of proteinuria, or the creatinine is rapidly increasing, urine showing some microscopic blood. These are things to suggest some other disease other than diabetes. It can be an immune mediated disease which is happening in a diabetic. So there we biopsy. That is about diabetes. Otherwise, with no other comorbidity, somebody like this coming with proteinuria, which is unexplained. We don't expect just hypertension to cause persistent proteinuria. We biopsy to find out. If we see elevated creatinine unexplained, many times we biopsy to find out what is a kidney disease. Unless we have evidence to say the kidneys are shrunken, small, already the disease is old, many times we defer biopsy. Otherwise, when there is a strong suspicion of a glomerular disease or when things are unclear, we always biopsy to find out the reason. Okay. Now, glomerular disease treatment, again, there are non-immunosuppressive treatments, which includes what I had previously mentioned, that is AIIMS and SGLT2 inhibitors. SGLT2 inhibitors are no longer only diabetic medicines. They are even used in diseases like IgA nephropathy and other proteinuric diseases where it helps to control the proteinuria. And there are immunosuppressive and immunomodulatory medicines like corticosteroids, MMF, tacrolimus, cyclophosphamide, rituximab, and a lot of newer drugs which are coming to manage the glomerular diseases. And these are generally given in the early stages of disease. When you happen to find out the disease by a biopsy in early stages is when we offer these immunosuppressive treatment. Unfortunately, if the creat is already elevated beyond a point and the GFR is low, then we may not be able to offer many of these immunosuppressive treatments. Okay, so just to recap, we discussed briefly about diabetes, how to manage diabetic kidney disease, how it's important to pick it up early. And if picked up early, and in fact, at every stage, right treatment can significantly delay progression and retard, or halt the progression. Glomerular diseases we discussed. High blood pressure itself can cause kidney disease. Adequate BP control will go a long way in preventing kidney damage. Interstitial diseases are again another group of diseases wherein how do you manage it? If you ask me, these anti-proteinuric measures, then blood pressure control, there is lifestyle modification, diet, good diet, weight management, and of course we manage the acid base levels, the calcium, phosphorus, uric acid. These things, if well managed, will again slow the progression of kidney disease. Drug induced kidney disease also has to be managed, certain general measures, and then we of course stop the drug. Cystic kidney disease, there is a condition known as ADPKD, autosomal dominant kidney disease. Generally there will be family history. In this also we have now certain medicines like tolvaptan which can slow down the cyst formation, and there can be dietary modifications which can go a long way in retarding progression. There are specific diets for each type of kidney disease. That is another thing I want to stress. As soon as somebody hears kidney disease, there is a general perception: stop all protein, restrict water, restrict potassium. So this is not a general kind of an instruction for kidney disease. So we have to manage the diet according to what type of kidney disease it is. Again, very important to understand. Inherited diseases also, there are different types of inherited diseases, and disease specific treatments can be offered at every stage. Now, till now we discussed about chronic kidney disease. So another entity is acute kidney injury. Okay, I would like to highlight with a case. This again a case which I managed. Young lady recently married, had a spontaneous abortion. had recurrent vomiting. She went to a local physician, was given a course of antibiotic and antacid and a painkiller. Very common group of drugs, nothing extraordinary, which is commonly prescribed. 10 days later, she had reduced urine output and swelling all over the body. Presented to us, serum creatinine was 13 milligram per deciliter. She was started on dialysis. Ultrasound showed normal sized kidneys and everything looked acute. She did not have hypertension, no other risk factors. We did a kidney biopsy and it showed acute interstitial nephritis, which was drug induced. Her kidneys had reacted or had an allergic reaction kind of a thing to one of the medicines which she had taken. We started her on steroids, IV and then oral. She had a complete renal recovery with a creatinine of 0.8. Okay, so this case is, see, from 13 creatinine, the creatinine became 0.8. So this case, I'm just trying to highlight that all kidney diseases do not mean that it is a permanent damage. All dialysis does not mean it is permanent dialysis. Each case is different. Chronic kidney disease is very different from an acute kidney injury. And if you hear that, oh, some patient has been cured of kidney disease by going somewhere, you would be hearing stories like this. Some of these acute kidney injuries recover. In fact, many of these acute kidney injuries recover on its own if given time. Okay, so it is not a magical cure which has cured the kidney disease. Acute kidney injuries have the potential to recover on its own. Whereas chronic kidney disease, if you go and try here, there, that medicine, this medicine, it is not going to work. The proven treatments I have just discussed with you. Okay, so acute kidney.
Ma'am, how will we differentiate? Is it acute or chronic?
Correct. So again, a very, very good question you have asked. There is no simple test to differentiate acute versus chronic. That is the first point to understand. We as nephrologists, we take into account various factors. In fact, many times it is difficult for us also to say whether it is acute or chronic. Whenever in doubt, we presume it could be acute. We presume there is a potential to reverse it. And we evaluate, we try all treatments possible in an attempt to reverse the acute kidney injury. Okay. Some of the pointers, for example, on ultrasound, if the kidney size is small, kidney size small on ultrasound is an indicator for the disease being long standing. If we find very high phosphorus values, if we find low hemoglobin, these are some of the indicators that the kidney disease is chronic or long standing. Okay. Then there are certain tests like parathyroid hormone levels will go up in chronic kidney disease. And another thing is acute kidney injury. Usually we'll be able to find out an inciting event. Like for example, in this patient, she had a presentation with some vomiting, medicine intake, and then she presented. Okay. Whereas in a chronic kidney disease, usually the patients will be very minimally symptomatic, very minimal symptoms, some fatigue, vague kind of symptoms. Acute kidney injury patients are more sicker. They may even have a fever. After fever, malaria, dengue fever, and all, patient can develop AKI, acute kidney injury. So these are some of the factors, and clinical judgment and laboratory investigations will help us in differentiating. Now, what to do if you have been diagnosed only in your late stages? So what I want to stress upon here is kidney disease, even if diagnosed in very late stages, is very well manageable, and kidney diseases are compatible with a fruitful life. So you have to prepare for a renal replacement therapy well in advance. The sooner you start preparing, the better it is. Not just physically, you have to prepare financially. That is another thing I always tell my patients. If you are diagnosed with chronic kidney disease and you know that this is how it is going to be, prepare your finances, prepare your other things, and also you have to start preparing for a vascular access. Once you need dialysis, you discuss, of course you have to discuss with your nephrologist what are the different options of dialysis. There is hemodialysis, peritoneal dialysis. How do you want to start the dialysis when that stage comes? Create a fistula when the best is to create an AV fistula well in advance. Ensure good nutrition. We find many times patients restricting everything. They restrict their protein entirely, telling my creatinine has come down. That has no value at all. If you restrict the protein, your muscles will start breaking down and naturally your creatinine will come down. But your kidneys are the same. The kidney function is the same. Creatinine is not a perfect marker, and if you restrict your proteins completely, your muscle mass reduces, creatinine also reduces. But the kidney function is the same. Do not restrict nutrition. You will be malnourished, you will become weak, and once your body needs dialysis, your body will not be able to tolerate dialysis. So good nutrition is very important. Dialysis initiation when it is required. Be prepared, be aware what are the symptoms or when is the time to start dialysis. Once your doctor, your nephrologist advises it is time to start dialysis when you are relatively okay. I would say don't wait for an emergent situation. If there are indications, better to start hemodialysis. And bottom line is, the best form of treatment for kidney disease advanced stages remains kidney transplantation without doubt. And it's been shown various studies that kidney transplantation provides much longer lifespan, much higher quality of life to patients suffering from kidney disease. And so kidney transplant can be a living donor transplant or a deceased donor transplant. It provides improved longevity and quality of life. Our patients get married, have children, they attain professional and personal success after kidney transplant. And I've just put two beautiful ladies' photo here. Some of you may recognize. On the right side, this is Selena Gomez. She's a famous singer. She was suffering from lupus nephritis and she progressed to end-stage kidney disease. Her friend donated a kidney and now she's again, back to normal, singing to glory. So, and she's a famous actress, Sarah Hayden, and she in fact had two transplants. The first transplant, father was a donor and the graft failed, and then second transplant, the brother donated. She's doing everything that a normal person does. So kidney transplant is really form of treatment which can change the life of end-stage kidney disease patients. And if for example you don't have a donor and you have to be on dialysis, even dialysis gives reasonable quality of life. You just have to adjust your lifestyle accordingly, and you can very well live a fruitful life with kidney disease. So I would like to end with that statement that it's important to diagnose kidney disease early to prevent progression. Unfortunately, we still see a lot of patients in later stages of kidney disease. You should not lose heart if you are diagnosed at later stages. Kidney disease are manageable at every stage with right treatment and right guidance. Don't get disheartened at any stage of kidney disease. Thank you. I'll be happy to take any questions from the audience.
Ma'am, we have some questions. Ma'am, before taking the question from the audience, I have some question.
Yeah.
Ma'am, as we know, diabetes is one of the major factors for kidney disease. If a patient with a controlled diabetes can be a donor or not?
Correct. So a couple of years ago, diabetic donors were largely rejected. We would not take diabetic donors. But now we have evidence from the Western countries as well as our country that diabetic donors with strict control and certain criteria can donate. Because now we have data of diabetic patients, sometimes those who have single kidney to begin with, or somebody who had to remove their kidney for other reasons, and we have seen how they generally progress with adequate sugar control. So yes, now we are accepting diabetic donors. Many centers worldwide and even our center, we do take diabetic donors, but we have certain strict criteria. They should not have any evidence of end organ damage and duration after diabetes diagnosis, and we follow certain strict criteria, and if they fulfill the criteria, they can donate their kidney.
Ma'am, if a recipient receive a diabetic kidney, will she be a diabetic patient?
No. So diabetes is something which is it is not, the diabetes as a condition, it is not arising from the kidney. Okay, so the reason why you develop diabetes, one is you're having reduced insulin production from pancreas itself. Second thing is insulin resistance. That means your body is not able to utilize the insulin. So both these mechanisms are originating outside your kidney. Your kidneys do not in any way give rise to diabetes, even if it is from a diabetic donor. But having said that, transplantation and the transplant medicines can predispose you for developing diabetes. It is not the kidney, but it is the medicines and the the immunosuppression and things like that which can predispose you to diabetes.
Okay, ma'am. One question, we have some confusion. Some of the nephrologists are suggesting bisphosphonate and some are restricting. Is it safe or not for transplant on kidney patient?
Right. So bisphosphonates, largely there are renal safe, kidney safe bisphosphonates which can be given even in post-transplant setting. But yes, many nephrologists have reservations on their use because we do not have long-term data, and we do not use it as a routine. In certain patients who have received long-term steroids prior to transplant, and then again they are on steroids, bone mineral density is low, there are specific indications wherein we use. Usually it's given as a weekly dose for a couple of months. I have used, it's largely safe, but yes, we do not have very strong data, so there are some reservations regarding the usage, but it can be used when indicated with close monitoring.
Okay, ma'am. One question from Muhammad Asraful Alam. I am looking for a second kidney transplant. My antibody levels are too high. It's about 7,000 MFI. For the first 2-3 years, all donor tests resulted in CDC and flow cross-match negative, but now all donor tests, CDC and flow cross-match got positive. I need to know how to reduce antibody levels and achieve CDC negative results to avoid losing potential donors. Can I stop searching searching donor?
Okay. Yeah. So sensitization, yes, transplantation, first transplant acts as a sensitizing event, and your body develops antibody to certain antigens. So in such situations, there are 2-3 things which can be done. One is, if you're waiting for a living donor transplant, we'll have to look at what exactly are the antigens or HLA, antigens against which you have antibodies. So the 17,000 MFI, what are the different antigens against which you have antibody, that we'll have to see. So in a living donor, we'll have to search for technically a donor wherein the donor's antigens and your antibodies, it's least incompatible. That is what we call least incompatibility. That is point number one. Secondly, there is something known as desensitization. We try to reduce your antibody production. There are medicines which can be given for that. And around the transplant time, there can be plasmapheresis. Plasmapheresis can remove your HLA antibodies. So it depends whether you are waiting for a living donor transplant or a cadaveric program. In a living donor, we'll have to really screen and see what are the HLA antigens against which you have, and then we have to find a least incompatible donor. Okay, that is how it should be done. Yes.
Okay, ma'am. Another question from Masum Billah. I had a kidney transplant 2 years ago. Last May, my biopsy report showed IgA nephropathy recurrence. For this, I am taking immunosuppressive medicine along with losartan potassium 25 mg, remifil 1.2 mg, and atorvastatin 5 mg. My blood pressure remains at 108 to 80. Is this treatment sufficient?
No, this is a right treatment which is being given, and I think it may not be appropriate for me to comment on specific treatment but this is largely the kind of treatment which is given for IgA nephropathy recurrence. We give ASABs, we try to maximize the dose. We also give SGLT2 inhibitors. So everything has been given, and immunosuppression, we try to keep it slightly on the higher side, and then monitor your proteinuria. Okay, so the right treatment has been given. The dosages and other things, of course, whoever is treating you would be able to adjust it. There are a lot of factors involved, and it's not a simple, thing. It's a case-to-case decision. That best person would be your nephrologist to adjust your dosage.
Ma'am, one more confusion. He is taking a mixture of losartan, potassium, and remifil together. Is it safe for
Correct. So, see, these are things. I mean, I'm sure it started by a nephrologist after, after giving good thought to it. So, I do not really think that it's appropriate for me to comment on this forum. Whenever we talk about treatment guidelines and all, there are also patient-to-patient situations. There are center-to-center protocols and a lot of such variations. So, I really would not want to comment about that. But it is we do not use it very commonly, but yes, there are difficult situations wherein certain nephrologists do resort to
Okay.
we have to resort to some unusual therapies also. So I mean it is really up to you, have to discuss with your treating nephrologist.
Okay, ma'am. Another question from Rafi Azmira. What type of measures we should take if biopsy shows acute tubular injury and creatinine fluctuating?
So this is again, I assume this is in a transplant setting. Transplant setting, ATI, acute tubular injury. See, ATI can potentially recover. That is the significance of ATI or acute tubular injury. We have to find out if there is a cause identifiable for ATI. Many times high TAC levels can result in ATI. So TAC level optimization, and sometimes we even see that even not very high TAC, but they are having creatinine fluctuations in ATI. We try to keep it at a lower level, because sometimes trough TAC levels, what we measure, may not really indicate your tissue TAC level. So there are certain issues like that, and so sometimes we may have to do an AUC TAC if the TAC is not correlating with ATI, if it is a persistent elevated creatinine, and or we have to rule out any other cause for ATI. So we have to try to find out a cause for ATI, and of course, if the creat is not settling, then we have to reassess if there is any reversible factor. ATI technically is a reversible situation, so we have to try to find the cause for ATI.
Okay, ma'am. We have another question from Raihana Begum. Good evening. Tacrolimus level ups and downs, and last month it was 72.9, and tacrolimus dose is 1.5 twice.
Rafi, I think
now,
specific situations, I think it's better. I mean, we do not discuss, right? In general questions, we can answer.
Okay.
This will be better.
Ma'am, got
Discuss with the doctor.
Okay,
yeah, because a lot of factors, TAC level and all, we do not, just like that, we cannot comment, right? The treating doctor would only know what is the background and all that.
Okay, ma'am. One more question. রায়হানা বেগম, আমি আপনার এই বিষয়ে একটু পরে কথা বলবো। আমরা হচ্ছে গ্রুপে এটা নিয়ে আলোচনা করব পরে। আচ্ছা ম্যাম, another question is from different individual, and is it safe to take frozen food for a transplant patient?
Frozen food per se, see, processed food, if you are taking frozen food. See, frozen meat and all will have, I mean, I don't know, they can have additives, preservatives and all that. That is in general not so healthy. The best is to take fresh cooked food as much as possible.
And someone or some taking fruits, vegetables in freeze and refrigerator and then it is taking, is it safe?
See, largely, there's nothing to say that you should not eat at all, but very much old and multiple times reheating is not considered very healthy. So the food, as much as possible, freshly prepared, but sometimes eating what is stored in fridge, I mean, I wouldn't really say, unless if it is home cooked, then, clean, shouldn't be a problem.
It's quite impossible who lives in urban area.
Correct.
Yeah. One question from a transplant individual. He was taking dialysis more than 1 year. First 1 year he was good, have strength enough, and now day by day he is getting weak and weaker. And his report is almost same, and creatinine and hemoglobin level is okay. Taking dialysis twice out.
He's on dialysis now?
Yeah, he's on dialysis. Is there any option for making him more strong?
Okay, if he's eating well, he has to take more protein in his diet. Dialysis patients, many times, the protein intake is we have seen that it is below what is prescribed. Dialysis patients, in fact, should take extra protein. And if somebody is not a diabetic, they should also take extra calories. Even diabetics should have calories. They will have to split it up and eat. High calorie and high protein diet is important in dialysis patients largely. And exercise, especially strengthening exercise, your muscle groups, you have to do strengthening exercise. While on dialysis, we many times see that muscle atrophy happens. Muscles slowly become weak, and that will lead to overall sense of weakness and fatigue and all that. So doing regular exercise, not just walking, but you have to do individual group muscle exercise. Eating good quality protein and calories will actually go a long way in improving your overall strength and well-being.
Okay, ma'am. Ma'am, we have some question. Ma'am, as far as we know, CKD is totally irreversible, but can it be got stuck in one stage with diet or medication?
Right. Yes, it can be. That is what we are trying to tell, that it can be halted at one stage. Okay. There are medicines now which can significantly halt the disease. That is the whole point I am trying to enforce, that you should not feel that it is chronic kidney disease, nothing can be done. That is not how it is. There are medicines which can halt the progression.
Okay, ma'am. Another question from many of us. Some of us are taking same dose of tacrolimus level, but tacrolimus tablet, but tacrolimus level got fluctuate in different time. Is it okay?
See, tacrolimus level, if it is fluctuating within a
Fluctuating
range,
in the same dose.
Within a range, it is okay. If it is too wide fluctuations happening, then we have to see if it is sometimes change of brand, or sometimes same brand, different batches can have some difference of bioavailability. The time of the day you're taking in relation to food, these are some of the things which can alter. There are some medicines, if you're taking with tacrolimus, recently you've taken some medicines which can interact with tacrolimus, these are some of the reasons it can fluctuate. So if it's fluctuating too much, some minor variation within that range is okay. If it is too much fluctuating, then you will have to see what is the reason, because it is not good. If the values are fluctuating too much, it's not good for long-term, graft health, kidney health.
Okay. Is there any body metabolic issue there?
See, TAC metabolism is a very complex kind of metabolism. So each person, you know that there is a genetic predisposition. You can be a fast metabolizer or a slow metabolizer. So same dose, two different individuals can have totally different levels. And also within the body, metabolism can be affected by certain other medications which you may be taking along with it. Having said that, certain food items can also affect your tacrolimus metabolism. So that is why the relation to food is important. But if things are stable, still the levels are fluctuating, then we'll have to look at, if there is something we are missing out, if the fluctuation is too much.
Ma'am, one question. Many of us have monetary issue. So someone can take high level of tacrolimus level. So they are using ketoconazole or cardizem. Is it okay with that?
It is okay, I would say. See, this is a situation specific to our country, India, Bangladesh, where we do not have, we do not have government funding most of the programs, and most of the patients are paying out of pocket, and there's a lot of expenditure. So missing dose becomes tricky. If you miss dose because of lack of funds, then kidney can reject. And in such situations, augmenting tacrolimus with these ketoconazole, diltiazem, these are well established, and we have been using these for many patients, and they are doing well. It can be done. Only thing again is it should be consistent. You cannot just skip. You think that tacrolimus is important, but diltiazem and ketoconazole, if my stocks are over, I skipped for 2 days. That you should not do. So it is as important as your tacrolimus. If you're taking it with tacrolimus, it becomes as important as tacrolimus tablet. You cannot skip it even a single day. So that is important. If you're taking with it, you have to be consistent, and you have to, of course, check your levels as advised by your nephrologist, and it should be not a
That means I
problem.
have to stick on one drug.
Correct. Whichever has been advised. Sometimes, I mean, usually it is one of the drugs which is advised, ketoconazole or diltiazem or whichever is advised to you, and in the dose that has been advised, that has to be taken without fail. What I meant to say is, you are told that your tacrolimus, MMF, and steroid are the three most important drugs for transplant. But if you are on, let's say, ketoconazole for attaining adequate TAC levels, ketoconazole also becomes equally important. That is what I was saying.
Ma'am, one question. We have some special individual who are someone are steroid free, some are tacrolimus free for more than 18 or 20 years. Is it recommended to get tacro free or Visolon free or MMF free?
So, see, transplant immunology, it's a very, very complex subject. Okay. So even though we have lot of advances in understanding, immunology and how to modulate immunology, we still have lot of areas which are difficult to explain. Like you rightly told, there are some patients 25, 30 years post-transplant who are probably on just some small dose of steroid and azurite. They are not even on tacrolimus. We have seen such patients. So there is an entity known as immunotolerance. Over a long period of time, your body becomes tolerant to that transplanted kidney. It somehow doesn't mount so much of an immune response. It tries to, or it starts to recognize the kidney as partly been there for a long time, as a part of the body, you can say, in simple terms. Immunotolerance is a known entity, but again, we cannot predict who all have immunotolerance, who are going to develop immunotolerance. Today's date, we don't have the technology or the advancement to predict who are going to do well and who are not going to do well, in whom we can take off a medicine and whom we have to be more aggressive. We do not have such very specific metrics to predict that. So it is only, I would say, trial and error. There are, of course, now there are certain indications wherein tacrolimus has to be taken off. Sometimes we introduce everolimus and a low TAC and MMF. Sometimes we have to take off TAC completely. Steroid, we may have to withdraw. Steroid withdrawal is now used in many centers. So it is, I would say, see, steroid, of course, steroid withdrawal is a thing wherein very low dose steroid or complete off steroids has been tried and patients doing well. But taking off tacrolimus and putting on only two drugs, if that is what you're saying, MMF and steroid, is really tricky. As I told, we cannot really predict who is going to act, behave how. So lot of patients also develop severe rejection and lose their grafts. We have seen so many who, for various reasons, have skipped doses, develop rejection, and lose their graft. So you are probably only seeing those few who have been lucky and surviving 25, 30 years on two drugs. So you are not seeing the whole picture. So that is a very skewed kind of data. We cannot really tell. So many would have lost their grafts for various reasons. So at today's date, we cannot really do that as a protocol, but probably down the years we'll be able to better predict the immunity, the immunotolerance, and we can tailor make better.
Okay, ma'am. One question. One day I meet with Professor Moon, a Korean nephrologist, and after 3 years of my transplant, he said, your tacrolimus level should be 6 or 7, or at least 5. But when I talk with my Indian nephrologist, he says 3 or 4 is enough. In Bangladesh, some of us says 3 or 4, some are saying 4 or 5. And what should be the ultimate tacrolimus level after 3 or 4 years?
Correct. So, see, again, in this, there are certain gray areas, I would say. Okay. So, there is something known as your overall immunological risk, which we assess. That what is your risk of developing long-term graft failure or developing an immune-related graft loss in the long term? We assess that. And then in those, for example, you had some preformed DSA, or you're very young, we anticipate some immune rejections, or you had some issues, or let us say you had some rejection treated, or there are certain other things also. We try to keep the tacrolimus slightly on the higher side, around 6, I would say. If not, we try to keep it around the lower side. See, 4 to 6 is a normal range, what most of the people follow beyond 1 year of transplant. Whether it should be 4 or whether it should be 6, again, depends on a lot of factors. We try to keep it on the higher side, 6 plus, around, if you are at a higher risk of rejection, we feel, or if you had infections, or you are overall, we feel you're over immunosuppressed, you're prone for infection, we try to keep it lower. In fact, with severe infection, we have even try to keep TAC levels much lower, around 3. So it is a very individual kind of a thing, and I would say your nephrologist would be the best person, because your entire history has to be dealt with in detail. It is not just one golden number kidney, your TAC level, if it is 6, or if let's say if your TAC level is 7, that means everything is fine. So that's unfortunately not how it is in transplant. There are a lot of
high TAC level create finger tremor.
Yeah. Higher TAC level will cause
a question from all: what is the best way to consume tacrolimus or mycophenolate, and what should be the difference?
I think we are getting most of post-transplant questions. This I think we dealt last time also.
Yes, ma'am.
So I was hoping that people will become more aware of how to detect and how to prevent kidney disease. That message should go in more. Of course, I understand you have a lot of large transplant community. Transplant community have their own concerns.
Yes.
So tacrolimus, I think last time also we discussed, you have to stick on to the same time. If you are taking before food, you have to stick on to before food, morning and night. If for some reason you have been told to take it after food for whatever GI intolerance or something, you have to stick to that. So that is pretty much what it is. Okay. So the overall message I want to drive in is that kidney diseases are very well manageable at every stage. Early diagnosis is very important. As transplant recipients, you can create awareness among the general public how kidney diseases are silent and how they should get tested, because as you rightly pointed out, most of our people are poor. Kidney disease is a costly affair. So let us try to prevent kidney disease from progressing. Especially our country, India, Bangladesh, we have a lot of majority people are poor. You cannot afford kidney failure. So let us try to prevent kidney disease from progressing to that stage. If at least give that additional 10, 15, 20 years wherein they can, plan their finances, things like that. And as far as possible, stop it from progressing to dialysis requiring stage. So that is one thing I want to stress upon with this talk.
One question. In Asia, we are taking less protein than Europe or America, but we are the most sufferer. What is the main reason?
Yes, so it is not really the protein which is causing the problem. We have many other reasons which is causing the problem. One most important thing is our diabetes. Okay, diabetes is one very common thing. Second thing is our lifestyle and the metabolic risk. We are predisposed to develop high BP. We are predisposed to develop high cholesterol, borderline high sugars. We are predisposed to develop obesity. These are things we are genetically predisposed. And on top of that, lot of environmental factors, our lack of hygiene in the food, exposure to certain, even pesticides and the weather, tropical weather, these are all contributory factors for kidney disease. Again, another important thing contributory is the lack of awareness, poverty, wherein getting yourself tested without any symptoms is the last of the priority, correct? When you're struggling to meet your needs, when you're struggling to feed your family, how can you even afford to get yourself tested without any problem? When you have problem itself, you don't have money to get yourself tested, correct? So without any symptoms, getting yourself tested, getting yourself treated. So these are all problems which push the diagnosis to later stages. We are not able to pick it up early because they are not able to come to the hospital to just get tested. So naturally, we diagnose it in very late stages. So these are all the factors contributing to kidney disease burden, and it's not really the protein intake. Okay, there is significant contribution by your lifestyle, genetic predisposition, environmental, socio-demographic factors. These are the reasons, and awareness is also a factor. People have to become more aware.
Okay, ma'am. Ma'am, thank you, ma'am. We haven't any question now. Thanks a lot for being with us.
Sure. My pleasure.
Thank you, ma'am. Thank you.
Okay, take care.